Disaster Nursing into two parts. We'll start with part one. Patients with life-threatening or potentially life-threatening problems enter the hospital through the emergency department. Many more patients report to the ED for less urgent conditions. Over 115 million people visit EDs annually. This number is increased for a variety of reasons, including the inability to see a primary care provider, an aging population, shorter hospital stays resulting in frequent readmissions, acute mental health crises, and the lack of insurance or a primary care provider. These factors result in chronic overcrowding and long wait times in many emergency departments. The triage process works on the premise that patients who have a threat to life must be treated before other patients. The ESI includes a triage algorithm that directs you to assign an ESI level to patients presenting to the emergency department. The primary survey focuses on airway, breathing, circulation, disability, and exposure, and identifies life-threatening conditions. If life-threatening conditions are related to ABCD and they're identified during the primary survey, interventions are started immediately and before proceeding to the next step of the survey. Nearly all immediate trauma deaths occur because of airway obstruction. Saliva, bloody secretions, vomitus, laryngeal trauma, dentures, facial trauma, fractures in the tongue can obstruct the airway. Patients at risk for airway compromise include those who have seizures, near drowning, anaphylaxis, foreign body obstruction, or cardiopulmonary arrest. Maintain the airway in the least to the most invasive method. Open the airway using the jaw thrust maneuver, suction and/or remove foreign body, insert a nasopharyngeal, oropharyngeal airway, and then endotracheal intubation. If you're unable to intubate because of airway obstruction, an emergency cricothyroidotomy or tracheotomy is performed. Jaw thrust maneuver is the recommended procedure for opening the airway of an unconscious patient with a possible neck or spinal injury. The patient should be lying supine with the rescuer kneeling at the top of the head. The rescuer places one hand on each side of the patient's head, resting his or her elbows on the surface. The rescuer grasps the angles of the patient's lower jaw and lifts the jaw forward with both hands without tilting the head. Rapid sequence intubation is the preferred procedure for an unprotected airway. It involves sedation or anesthesia and paralysis. Stabilize the cervical spine with the head maintained in a neutral position and/or immobilize during assessment of the airway. At the scene of the injury, the cervical spine is immobilized with a rigid cervical collar or a cervical immobilization device, also known as head blocks. Many conditions cause breathing alterations, including fractured ribs, pneumothorax, penetrating injury, allergic reactions, pulmonary emboli, and asthma attacks. Life-threatening conditions such as a tension pneumothorax and a flail chest can severely and quickly compromise ventilation. If a pulse is felt, assess the quality and rate. Assess the skin for color, temperature, and moisture. Altered mental status and delayed capillary refill, which is longer than 3 seconds, are the most significant signs of shock. Take care when evaluating capillary refill in cold environments because cold delays refill. Insert IV lines into veins in the upper extremities unless contraindicated, such as in a massive fracture or an injury that affects limb circulation. Apply direct pressure with a sterile dressing to any obvious bleeding sites. Obtain blood samples for typing to determine ABO and RH group. As you're determining disability, measure the patient's level of consciousness using the AVPU method, the Glasgow Coma Scale, and pupils. Once the patient is exposed, it's important to limit the heat loss, prevent hypothermia, and maintain privacy by using warming blankets, overhead warmers, and warmed IV fluids. The secondary survey is a brief, systematic process to identify all injuries. See Table 69.5 for more information. You get a full set of vitals, 5 interventions, and facilitate family presence. A complete set of vital signs includes blood pressure, pulse, respirations, oxygen saturation, and temperature. Do bilateral blood pressures. At this point, determine whether to proceed with the secondary survey or to perform additional interventions. Those focused adjuncts are considered for patients who sustain significant trauma and or require life-saving interventions during the primary survey. Patients report that caregivers comfort them, serve as an advocate for them, and help to remind the healthcare team of their personhood. General comfort measures such as verbal reassurance, listening, reducing stimuli such as dimming lights, and developing a trusting relationship with the patient and caregiver should be provided to all patients in the emergency department. Details of the incident are extremely important because the mechanism of injury and injury patterns can predict specific injuries. For example, a restrained front seat passenger may have a head injury or knee, femur, or hip fractures from hitting the dashboard and an abdominal injury from the seat belt. The history should include the following questions. What's the chief complaint? What caused the patient to seek attention? What are the patient's subjective complaints? What's the patient's description of pain? Location, duration, quality, and character. What are the witnesses' descriptions, if any, of the patient's behavior since the onset? What is the patient's health history? The mnemonic AMPLE is a memory aid that helps you to ask about the following. A is allergies to drugs, food, or the environment. M is medical history. P is past health history. L is last meal. And E is events and environment leading up to the illness or injury. Inspect the back for ecchymosis, abrasions, puncture wounds, cuts, and obvious deformities. Palpate the entire spine for misalignment, deformity, and pain. Evaluate the need for tetanus prophylaxis and provide ongoing monitoring and evaluate the patient's response to interventions. The nurse may accompany critically ill patients on transport. The nurse is responsible for monitoring the patient during transport, notifying the healthcare team should the patient's condition become unstable, and initiating basic and advanced life support measures as needed. You have a 32-year-old man arriving in the emergency department via ambulance. A neighbor found him lying on the rocks in the rock garden. He had fallen off the roof while fixing the shingles on his house. His femur is protruding through the skin. The paramedics report that he was found in a large pool of blood, unresponsive, BP 60/42, and heart rate of 168. What potential life-threatening injuries does he have? What is the priority of care? And what interventions are needed immediately? Well, first, head injury, abdominal trauma, and internal bleeding are the potential life-threatening injuries. The priority of care is ABC, airway, breathing, circulation. The interventions needed immediately include intubation, ventilation, fluid management, and type and cross for blood. When a patient dies in the emergency room, it's important to recognize the importance of rituals in preparing the bereaved to grieve. These can include collecting the belongings, arranging for an autopsy, viewing the body, and making mortuary arrangements. Whenever possible, provide an area for privacy, and if appropriate, arrange for a visit from a chaplain. Determine if the patient could be a candidate for non-heart beating donation. Tissue and organs such as corneas, heart valves, skin, bone, and kidneys can be harvested from patients after death. Approaching caregivers about donation after an unexpected death is distressing to both staff and caregivers. For many, however, the act of donation may be the first positive step in the grieving process. Organ procurement organizations are available to assist in the process of screening potential donors, counseling donor families, obtaining informed consent, and harvesting organs from patients who are on life support or who die in the emergency department. In the state of Maine, it's required that the organ procurement organization be notified of imminent deaths and that they be the ones that approach the family. Older adults are at high risk for injury primarily from falls. Of the injury-related admissions for people 65 or older, most are for fractures, with many of these resulting from falls. The three most common causes for falls in the elderly are generalized weakness, environmental hazards like loose mats or furniture, and orthostatic hypotension, which is the side effect of medications or dehydration. It's important to determine whether findings have caused the fall or may be due to the fall. Different kinds of diagnoses for patients that you'll see coming to the emergency department include heat exhaustion, which is prolonged exposure to heat over hours or days. This occurs when thermoregulatory mechanisms such as sweating and vasodilation and increased respirations cannot compensate for exposure to increased ambient temperatures. Strenuous activities in hot or humid environments, clothing that interferes with perspiration, high fevers, and pre-existing illnesses predispose individuals to heat stress. The clinical syndrome is characterized by fatigue, lightheadedness, nausea and vomiting, diarrhea, a feeling of impending doom, and tachypnea. It's also characterized by tachycardia, dilated pupils, mild confusion, ashen color, profuse diaphoresis, hypotension, and mild to severe temperature elevation, such as 99.6 to 104 Fahrenheit due to dehydration. Heat exhaustion usually occurs in individuals engaged in strenuous activity in hot, humid weather, but it also occurs in sedentary individuals. Place the patient in a cool area and remove constrictive clothing. Place moist sheets over the patient to decrease the core temperature. Provide oral fluid, replace electrolytes, and initiate a normal saline IV solution if oral solutions are not tolerated. Monitor the patient for ABCs, including cardiac dysrhythmias due to electrolyte imbalances. Salt tablets are not used because of potential gastric irritation and hypernatremia. Consider hospital admission for the elderly, the chronically ill, and those who do not improve within 3 to 4 hours. Heat stroke is the most serious form of heat stress. The patient has a core temperature greater than 104 degrees Fahrenheit, altered mentation, absence of perspiration, and circulatory collapse. The skin is hot, dry, and ashen. Cerebral edema and hemorrhage may occur as a result of direct thermal injury to the brain and decreased cerebral blood flow. Treatment is to stabilize the patient's ABCs and rapidly reduce the temperature. Cooling methods include removing clothing, covering with wet sheets, placing the patient in front of a large fan, immersing in an ice water bath, administering cool fluids or lavage with cool fluids, Administration of 100% O2 compensates for the patient's hypermetabolic state, and ventilation with a bag valve mask or intubation and mechanical ventilation may be required. Shivering increases the core temperature and complicates cooling efforts, and this is treated with IV chlorpromazine. Aggressive temperature reduction continues until the core temperature reaches 102. Monitor for signs of rhabdomyolysis, myoglobinuria, and disseminated intravascular coagulation. The muscle breakdown leads to myoglobinuria, which places the kidneys at risk for acute failure. Hypothermia is constituted by a core temperature of less than 95 degrees Fahrenheit. Risk factors include being elderly, certain drugs, alcohol, and diabetes. A core temperature of less than 86 is potentially life-threatening. Mild hypothermia is 93.2 to 96.8. Involves shivering, lethargy, confusion, rational to irrational behavior, and minor heart rate changes. Moderate hypothermia is 86 to 93.2 and involves rigidity, bradycardia, bradypnea, blood pressure by Doppler only, metabolic and respiratory acidosis, hypovolemia, and shivering disappears at a temperature of 86 degrees Fahrenheit. Severe hypothermia makes the person appear dead. Bradycardia, asystole, and fibrillation occur. The metabolic rate, heart rate, and respirations are so slow they may be difficult to detect. Reflexes are absent, and the pupils are fixed and dilated. Warm a patient to at least 90 degrees before pronouncing them dead. The cause of death is usually refractory ventricular fibrillation. Treatment of hypothermia is to manage and maintain the ABCs, rewarm the patient, correct the dehydration and acidosis, and treat cardiac dysrhythmias. Mild hypothermia requires passive or active external rewarming. Gentle handling is essential to prevent stimulation of a cold myocardium. Closely monitor the patient for marked vasodilation and hypotension during rewarming. Moderate to severe hypothermia requires active core rewarming, which includes the use of heated, humidified oxygen, warm IV fluids, and peritoneal and gastric or colonic lavage with warmed fluids. Consider cardiopulmonary bypass or continuous atriovenous rewarming in severe hypothermia. The risks of rewarming include an afterdrop, which is a further drop in the core temperature, hypotension, and dysrhythmias. Rewarming should be discontinued once the core temperature reaches 95. Afterdrop occurs when cold peripheral blood returns to the central circulation. Submersion injury results when a person becomes hypoxic due to submersion in substances, usually water. There are over 50,000 submersion events and approximately 4,000 deaths from drowning each year in the United States. Most of these victims are children under 5 or boys between the ages of 15 and 25. The primary risk factor for submersion injury is the inability to swim, use of alcohol or drugs, trauma, seizures, hypothermia, stroke, and child neglect. Drowning is death from suffocation after immersion in fluid. Immersion syndrome occurs with immersion in cold water, which leads to stimulation of the vagus nerves and potentially fatal dysrhythmias. Near drowning is survival from a potential drowning. This is a schematic of the pathophysiology of a submersion injury. Aggressive resuscitation efforts and the mammalian diving reflex improved survival of near-drowning victims. Treatment of submersion injuries includes correcting hypoxia, correcting acid-base and fluid imbalance, supporting basic physiologic functions, and rewarming if hypothermia is present. Table 6910 lists other interventions. The initial evaluation is ABCD, mechanical ventilation with PEEP or CPAP to improve gas exchange when pulmonary edema is present. Ventilation and oxygenation are the primary techniques for treating respiratory failure. Mannitol or furosemide, Lasix, is used to decrease free water and treat cerebral edema. Deterioration in neurologic status, cerebral edema, worsening hypoxia, and profound acidosis occur. Observe for a minimum of 4 to 6 hours. Secondary drowning is a concern with patients who are essentially symptom-free. Near-drowning victims may also have head and neck injuries that cause prolonged alterations in the level of consciousness. Complications can develop in patients who are essentially free of symptoms immediately after the near-drowning episode. This secondary drowning refers to delayed death from drowning due to pulmonary complications.